So the lab tests we discussed, the central point would be the BNP, a complete blood count for anemia, electrolytes to look at the kidney issues, as well as any complication of therapy, and liver function, especially if there's a right-sided failure or a chronic congestion to the liver, you could make that out. Now, the ECG again forms a very important central point of this patient, and 4 important things that we need to do is look at the QRS duration, look at whether the patient has a left bundle branch block, because that could have a very important prognosis if it is more than 150, and also could help us choose a therapy like a CRTD for these patients who are not responding to medical therapy. Left ventricular hypertrophy and atrial fibrillation, again a very important point where you would like to add a NOAC in these patients going along. Now, as I said before, echocardiography is a very important point. It's the hallmark of heart failure. So the ejection fraction, the dimensions, the valve motion, valvular abnormalities, either primary or secondary. We did mention that rheumatic heart disease also is a very important part of heart failure in the young. And most importantly, when we're looking at a HFpEF patient, the diastolic parameters become very, very important. Now, additional imaging studies like the X-ray, which is the only study which will look at the lung congestion or the lung vasculature, is very important. And it's very important to look at that lung X-ray before you move ahead. I will talk a little detail on the cardiac MR and nuclear techniques. Suffice to say that these techniques follow after the essential investigations are done, and echo gives you a certain direction point as to what this patient is having, ischemic versus non-ischemic. Then you would employ both these techniques to further elucidate what else this patient is having. So primary to the diagnosis of this young person's heart failure is the ejection fraction that we talked about. And as we know, the ejection fractions are different and they have different connotations in terms of prognosis, and also, like we know, in terms of treatment. So while echo is the central point for a heart failure patient's journey, once it is done, it's important to have a gold standard in terms of ejection fraction to make sure that any improvement based on your 4-drug therapy or the Fabulous 4 or any other therapy, whether it's CRT, will now be based on something which is the inter-observer variation is low. It's a windowless system of imaging, and you get a very good ejection fraction, volumetry, and also the mass. So this is a good and important gold standard before embarking on specific therapy for heart failure. And MRI is a very good tool, and this sequence can be done in about 10 minutes. It doesn't employ contrast and can be done very quickly and efficiently. And if you look at the recommendations, irrespective of the ejection fraction of these patients from mild, moderate to severe, CMR is the gold standard tool. And whether you've had an ischemic heart disease, MI, LV dysfunction, or if it is a non-ischemic, MRI has a very appropriate use in terms of quantification of LV function as well as volumetry. The second thing that we want to see in heart failure is whether this patient has a coronary artery disease or not. And this has traditionally been done by the angiography. And if you look at Felker's data, you will see that the ischemic subsets always fared worse whenever they were the cause of heart failure. And because of this, traditionally we have been using the coronary angiogram. You can see the normal angiogram on the left, and here there is an LAD occlusion, as a means to ascertain whether this patient who's come with a severe LV dysfunction, global hypokinesia, has an underlying CAD or not. But what we have also discovered over the years is that the cardiac MRI, not only being an important point for volumetry injection fraction, also has a means to tell us what the underlying basis of heart failure is for this patient. And if you look at the orange arrow above, you will see the very typical subendocardial delayed enhancement, which is there both in the inferior septum as well as the basal anterolateral wall, compared to the next patient, which is the mustard arrow. You will see that the scar here is actually mid-myocardial, and there is a space between both aspects of the scar, suggesting that there is no vascular etiology in this patient with heart failure. And the third type of patient is a patient who has what is called a subepicardial kind of scar, especially involving the infralateral wall, and usually seen in younger patients after a typical viral syndrome. And we saw a lot of this during COVID, which is suggestive of myocarditis. So without resorting to an angiogram, by the use of MRI, you can have a fair idea about the underlying cause of the heart failure. And now what we are doing is we are employing what is called a T1 mapping sequence. So single stain, no contrast, you get what is called T1 maps. And based on the disease, the T1 and the ECV, you get a whole host of diseases that can be looked at in heart failure, starting from iron overload patients right up to patients with amyloidosis, myocarditis, infarction, and even the hypertrophic cardiomyopathy group of patients based on their T1 values. And this does not employ using contrast again, can be done in 10 minutes. And then you have a good idea about the diffuse fibrosis which is there in these patients. So going forward, when you want to look at which technique is the gatekeeper, you have the echo tools, the SPECT and MRI, which have to be used in these kind of patients with severe LV dysfunction because of their high perioperative risk before you take them to the cath lab or intervene in terms of PCI or CABG. And all three techniques are good techniques, and all three techniques in the right hands, in the right institution, have a certain amount of validity. So we'll be just looking at some of them, and you will see that the echo techniques here have a very high degree of contractile reserve assessment and tissue volume loss, not to mention their easy availability, cost, bedside availability. The nuclear techniques again are very strong with metabolic, perfusion and membrane transport. And if you look at the MRI, it encompasses a lot of the echo features and nuclear features and seems to be a complete solution, although expensive and not freely available. So not only ejection fraction, which is important to classify these patients, we use echo for risk assessment, we use them for quantification of regurgitation, we use them for the assessment of diastolic function, the left atrial volume, especially in patients with HFpEF, and the RV, as we've seen, for looking at the right-sided disorders, and also for assessing patients who require a CRTT device. And when we follow these patients on echo, we will see the volume start dilating, the mitral regurgitation starts getting severe, and then they need to be intervened.